Hey guys, welcome. Thank you so much for joining us today. We've got people kind of coming in now. It's great to see the representation across the country. Welcome to the PHN Insight series from 360 Edge. We've actually had people sign up from every single state in Australia. We've had 31 registrations, so we're really excited to talk to you all across the country. Today, if I could start with a quick acknowledgement of country. I'd like to acknowledge the traditional custodians of the land and waters on which we live and work and pay our respects to elders past, present, and future, for they carry the cultural wisdom and stories, traditions, and dreaming. With a commitment to reconciliation, we acknowledge the ongoing impact of past policies and practices and commit our endeavours to creating a just society and sector that celebrates the ongoing resilience and self-determination of our First Peoples and communities. So welcome again, everyone. A few more people joining in. The inception of this kind of series is coming from 360 Edge. We're an AOD specific consultancy that works with governments, now over 15 PHNs across the country, with a focus on AOD specifically. So we have this niche expertise in that area. And actually having a chat with Mel over in Waffa, who's joined us on here today, we were talking about how there needs to be perhaps better sharing of insights and innovation across the country for AOD support and services. So we wanted to get this series going, and a quick 30-minute session to provide an open forum for people that have been in PHNs working in AOD for a while, but also new people to come in and learn something and share knowledge. So today we wanted to focus the conversation around the NICE, the National ICE Action Strategy, of which 360 Edge did the evaluation for the federal government. So what we're going to do is Dr. Nicole, Professor Nicole Lee, will share her kind of background of the methamphetamines in Australia, and then Dr. Richard Cash, both from 360 Edge, will go through some of the insights that are relevant for the PHNs. What I would actually love you to do is, and encourage you, is down the bottom you'll see a Q&A box. Please feel free to ask questions, and Richard or Nicole can answer a lot while the others are talking, but we can also have an open forum after the 15-minute presentation for discussion. So with that, I'll hand over to Nicole.
Thanks, Chris. And welcome, everyone. I'm just going to do a little bit of a background, kind of take you right back to the beginning of NIAS. Some of you I know have been around for a very long time and will remember this, and some of you may be kind of newer to the history of it. But if you kind of cast your mind back to around 2014, there was a measurable shift, which even if you weren't working in the sector, you will have seen in reporting in the media, and also increased concern in the community. And most people in the community get their information about drugs from the media. So as the media started to kind of latch onto this, the community started to get more and more worried as well. And it's something that's kind of softened a little over time, but has never really gone away. There's still significant concern. In the last National Drug Household Survey, amphetamines were still the drug of most concern to the community. And although at the time, and continued, the rate of methamphetamine use declined and has continued to decline, and has followed a downward trend since the late 1990s, early 2000s. There was a shift in the availability and use of the stronger form of the drug, crystal meth, or ice. So ice and the powdered form are exactly the same drug, but the crystal meth is much, much stronger, and so it's much more likely to cause harm. And as well as that, in parallel to that, the rate of injecting and particularly smoking sharply increased as the availability of crystal meth increased, and that further increased risk. So along with those increased harms, what we started to see was an increase in people seeking treatment for methamphetamine related problems. And that escalated fairly quickly. So you can see from this graph, it was just slowly increasing over time. But around 2014, 15, up to 2015-16, it took a sharp increase. And in 2015-16, amphetamines, for the very first time since we've been recording drug trends, it took over from cannabis as the second most common drug of concern in treatment settings after alcohol. And there was also a whole range of other harm indicators, including ambulance call outs, deaths, and hospital admissions, which all also increased. So in 2015, the then Prime Minister Tony Abbott kind of sounded the alarm and announced the National ICE Task Force to undertake a national inquiry. It was headed by the ex-Victorian Police Commissioner Ken Lay, and the report was delivered to a new Prime Minister, Malcolm Turnbull, at the end of around the end of 2015, with 38 recommendations, most of which were accepted. And in December, Mr. Turnbull announced a significant amount of funding as part of the government response to that report. It was really, really significant at the time because traditionally, when there was a drug issue, most of the money was directed to supply reduction. But in this case, the significant proportion, by far the largest majority of the funding, went to treatment and support services, and most of that went through the PHNs in two different formats. So overall, there was a $450 million national program that was focused on reducing methamphetamine-related harms. And the NIAS National ICE Action Strategy included 30 activities, and they were organised into 5 priority areas, which corresponded with the priority areas from the National Task Force report. So better information for families and communities, prevention messages for high-risk populations, so secondary prevention, primary and secondary prevention, early intervention and treatment services. Some went to law enforcement, and then some later funding on top of that to law enforcement. And then the 5th priority area was developing the evidence base to ensure that our responses were consistent with best practice. So the PHNs played a particularly large role in NIAS under priority area 3, and received a whole new stream of funding as a result of that. And the brief at the time, which has kind of shifted and expanded over the last few years, but the brief at the time was to specifically expand sector capacity through the commissioning of new treatment and support services. And those services were amphetamine related, but they were a bit broader than that. So I'll hand over to Richard, who will talk a bit more about the NIAS evaluation itself and what we found. Richard.
Thanks, Nick. So 3.5, 4 years into NIAS, the Department of Health asked us to undertake a comprehensive evaluation. We started in 2019, late 2019, and finished in early 2021. There is a report available online if you fancy a read, but we're going to condense the key takeaways for you here today. What we essentially set out to find out is, has NIAS been implemented as planned? What have the performance been of each of those 30 activities, and how well integrated were they? So we adopted an evaluation approach that was quantitative. We looked at data and also qualitative. We did a lot of document review to try to define what those activities were and what their intended outcomes, how they'd operated. we spoke to about 300 stakeholders, including representatives from most PHNs, over about 100 hours of consultation. And we developed some common evaluation metrics. How well implemented has an activity been, and what have the outcomes been? And we used a cascade approach to find key informants. So we spoke to people who connected us to other people who were knowledgeable about the programs and the implications that they'd had. On the whole, implementation of NIAS had progressed really well. 30 of the planned activities were either in progress, were under development with some significant progress, or had been done and completed. And we were able to identify positive outcomes for 27 of those 30 activities, with the remainder showing a mixture of positive but also some unintended negative consequences. So on the whole, implementation had gone pretty well. From a process evaluation perspective, this was a thumbs up. The harder question though is to assess outcomes, and we ran into some difficulties about the quality of data across a lot of those activities. How well had people monitored the activity and how well it was performing, and how well did they report on that? So that was a limitation for us in doing an evaluation. Insufficient attention, essentially, when you're trying to establish a new activity fairly quickly, to think about how we're going to keep an eye on how this is travelling and what the outcomes are. Some of the activities had excellent evaluations and some not so much. Having said that though, we did certainly see a significant uplift in sector capacity. This was most importantly felt within the AOD treatment sector, but we also saw better access to information resources for the community, improved access to prevention, early intervention, harm reduction. We saw that professionals had better access to high quality information resources for treatment, things like treatment guidelines, and we saw an uplift in the data quality as well. We saw some synergy between activities that were primarily in demand on supply or harm reduction, so some evidence of coordination. And we made some recommendations around future improvements. But the interesting thing for us today really is the implications for primary health networks, for your role in mediating that outflow of funding. A really big finding here was that when you increase investment, you do see an increased set of positive outcomes. And this is something we heard from all of the stakeholders we spoke to, from representatives from the PHNs, the services that you're funding and the AOD sector more broadly, from the alcohol and drug peak bodies, consistently that more funding equals good outcomes. So they've boosted the capacity of the sector, but they also improved the capacity of PHNs in understanding and engaging with the alcohol and drug sector. And this is kind of a formal role. You fund services, you understand what services provide, you understand the service mix, you understand the sector, but also in some informal ways about the way PHNs help to support linkages between different sectors. Traditionally, the primary health and the AOD specialist sectors, but more broadly in that through the networking and particularly through workforce development, and these were really highlighted in our consults. We tended to see really positive outcomes when there was some flexibility in funding and commissioning. So when there were some targeted arrangements that looked at particular population needs, so it might be culturally and linguistically diverse populations, it might be LGBTQI plus populations, some really good evidence of targeted programs to support those folks. We also saw some regional targeting, really looking at what we know about what services might be lacking or needed in a particular region, or looking at a service mix and saying there's a lack of a particular program type, and PHNs being quite flexible in identifying resources need to flow to those services. And day rehab would be an example we found there. We also uncovered some challenges, and I've kind of mentioned the big one already, don't want to harp on it, other than figuring out how impactful an investment has been really depends on good quality data. And this was difficult, and this isn't just a PHN issue. Identifying and monitoring outcomes is an endemic problem within the AOD sector more broadly. Consistently tracking outcomes is pretty tough. Even determining what good outcomes mean within AOD treatment is pretty hard, and sometimes other funding models, so hospital bed stay, for example, don't apply to AOD environments. We notice some real challenges in terms of regionality. So particularly in remote and rural areas, there was a lack of availability of services. When new services are established, they struggle to find the workforce, or they can be set up, but they might risk cannibalising capacity from existing other services. We also noticed some regional variation in terms of outcomes, and I'll talk a little bit about what that means in a minute with respect to how PHNs engage. And lastly, it's really hard to achieve consistency. From an evaluation perspective, it's hard to compare across Australia in terms of the outcomes, but from a PHN perspective, there is a lack of guidance available, frameworks, if you like, to say, how should we plan? How should we coordinate the services that we fund? How should we monitor and evaluate the performance of those services? That lack of consistent frameworks to guide that oversight of AOD work, again, is a fairly endemic problem. And NIAS really highlighted this need. We need these frameworks to guide how we plan and commission and then monitor and evaluate services. And this would be a really important feedback loop for PHNs, and probably really reduce the admin burden for you and for the services that you fund as well. So bottom line, that regionality, that variation we saw, there were some really important predictors of when things worked really well. And it's things like good relationships with service providers, existing relationships, knowledge of the sector, good understanding of how the AOD sector works, good engagement not only with services but also with peak bodies. Where we saw those linkages, that understanding, those existing relationships, that capacity to collaborate, we tended to see better outcomes. And I think this really points to a potential role for PHNs in advocating on behalf of the AOD sector for what's required and where they do good work. But I think that's enough about the evaluation, Chris.
Amazing. Thank you, Richard. And apologies, I'm stuck under Queensland weather at the moment. So in case it's a bit hard to hear me. I want to go to the macro, and please feel free to pop in questions in the chat box or in the Q&A. But I'll start with Nicole. What's your, I mean, a lot of people in the PHN roles are sort of wondering what's going to happen next. Like, what's the kind of, where's the government going to go? And you have a role in ANICAD, and it'd be great, to get your perspective, even though it's, murky to everyone. But where do you see the landscape going? What are your kind of intuitions around that?
Yeah, look, it's a crystal ball question that no one has the answer to, obviously. But what I have seen, being in the sector for a very long time and living through several kind of ICE crises and a range of other things, is that we are moving more and more towards, or moving more and more away from drug-specific type of strategies and much more towards a more overall strategic approach to dealing with a range of drug and alcohol issues in the sector. And I think that is a good thing, because, it might be ICE one year, but then maybe something else will pop up another year. And if we just focus on specific drugs, then we don't have a sector, particularly the front line of the sector, that is flexible enough to kind of shift around and respond to whatever is in front of them. So I think this shift more towards a broader approach is really good. And we've also, I just did talk to someone in the media this morning actually about the new kind of the new medications that are based on psychedelics and MDMA and a whole range of things. And so I think that our thinking is starting to become a bit more strategic and bigger picture in relation to a whole range of drug specific issues, not issues, but topics.
Thanks, Nicole. so murky as ever and complicated. And Richard, like a big challenge that I know PHNs is around like how to commission well. Like, did you see anything in the the evaluation or Nicole that really were examples of really great commissioning processes with services that are kind of insights there?
Do you want me to jump in, Nick? Sure. Again, I think the best examples of commissioning where we saw less duplication of some of the work that services and peak bodies were doing around needs assessment in getting that service mix right. One of the big challenges in commissioning is the lack of transparency about who's funding what. That was one of the big challenges at Commonwealth and at state levels. There's no really good way of seeing what that service mix looks like. And in terms of finding a gap or drawing on outcome data and saying, well, this is clearly performing quite well, we should do more of it, that transparency isn't there. However, that's not to say that services and the sector, and particularly peak bodies as reps, don't understand where those gaps are and where the needs are. So one predictor of good commissioning was liaison with the peaks. Just one other point, I guess, is understanding some of the limitations for a lot of AOD services in responding effectively to tendering opportunities. They found that a real challenge. So some of it was just about admin taking time away from service delivery to respond. I mentioned some of the workforce stuff previously, but early on in NICE we saw some disincentives to be involved, and one is the short-term nature of those initial contracts, that services were pretty disinclined to throw their hat in the ring if they saw that this was limited term funding. This was particularly the case for Aboriginal community-controlled health organisations. Lots of implications of short-term commissioning in terms of sustainability, regional capacity development, workforce development. So when NICE contracts moved to 2 years, that was a really big improvement for a lot of services in terms of participation.
Awesome. And is there any specific programs that you saw, because you had such a wide-reaching kind of view of it, were any specific kind of treatment programs or innovations that kind of really stuck out as interesting and worth mentioning?
From a case study perspective, yeah, we did hear, and it was some of that special population, really targeted program stuff where a lot of thought had been gone into understanding the needs of a particular community or a group of people and targeting a service, its promotion, its service delivery, the service types that it offered to meet those needs. That was they were particularly impressive. Now, this is one of the evaluation problems, Chris, is we think those things probably happened quite often, but being less capable of representing and reporting on those outcomes means it's harder to find them. So we were kind of dependent in some ways on saying, PHNs particularly and services saying, we're really proud of this service that we funded, and here's some documentation, here's a review, here's an outcome study that we've done. That's fed into our planning process, and as evaluators we can look at that in-house evaluation or that evaluation that the PHNs funded and go, that's really strong evidence for the effectiveness of that approach, and that allows those approaches to disseminate. So I guess if you're going to do something special, make sure you keep the receipts.
We have a great question here from Mel. Was there any particular innovations supporting GPs specifically in primary care, like activities really unique to PHNs? I know it's not, it's a difficult thing around kind of methamphetamine engaging in primary care, but yeah, was there anything that, either you or Nicole saw that spoke to that?
Nicole, I don't know if you want to jump in, but there were some really effective brief and well-credentialed brief intervention tools for GPs that PHNs had a role in delivering. So the assist package, for example, would be brief intervention, really demystifies GP screening and assessment and brief intervention work, and PHNs played a role in making sure GPs were able to access that. face-to-face training, and then through COVID, some online e-learning, some flexible ways of accessing that. But PHNs certainly played a role in facilitating access.
Nicole, what was sort of some of your kind of, I know you're busy there typing an answer to Mel's first question.
I'm trying to think of a.
It's a very good question.
Shall I just answer it live then, perhaps?
I think you're going to get an essay, Mel.
Yeah, I was like, oh, how do I answer this? Look, I think that the thing is that it's a really good question. Who knows? Again, crystal ball question, but methamphetamine is still a real issue. Not that long ago, some of the ministers kind of went and did a bit of a roadshow tour around about the drought, and all anyone wanted to talk about was methamphetamine. So it's still a concern in the community. There's still increasing numbers of people wanting to access treatment. The sector is still severely underfunded. 10 years ago, it was underfunded by about half of the demand, and that kind of got better. It will have only increased as more and more people access treatment. And so it kind of suggests that obviously that funding is still required. It would be a deep disappointment to me if that funding got shifted out of the sector now that it's in there. But with the slow shift to a broader broader strategy across drugs rather than drug specific, I wouldn't be surprised if that funding source was maybe more coordinated between what was previously the non-government treatment organisation grants. Maybe there'd be a more consolidation of funding into the PHNs, but who knows? That's just my very random guess.
And this might not answer Melanie's question specifically, but I think understanding GP needs to understand drug and alcohol treatment and the sector and how to access it and what's available in terms of treatments, and to support practices to understand that their existing patients are people with alcohol and drug problems. So that destigmatising working with people with alcohol and drug problems is a really important part of what PHNs directly through supporting practice nurse roles. There's a whole bunch of stuff that GPs do to try to improve the capacity of primary care.
We just kind of rounding it out, and thanks so much for thoughtful questions there. I've popped in a survey in the chat box, and amazingly, we had 31 people register for this event, and we had 26 attendees. So it's obviously something that you're really passionate about and interested in. So we would love to keep doing these series going across different areas. So I put a Survey Monkey in there. This is our first crack at it, so please feel free to provide any feedback to improve it. If there's content that you'd like to learn about, we're thinking the next one that we'll do will be focused on the interaction between PHNs and state funding, particularly some work we're doing in Queensland, which we think there's some insights there we could discuss. But if there's anything specific to the AOD space, we'd love to really support you, because this is you got to stick together, and the sector is quite difficult, under-resourced, and we'd love to really work with each of you in making it better. So thank you so much. Thanks Nicole and Richard for sharing that today. Please feel free to reach out. The email's there if you have any questions further to that. We'll follow up with the report, and if you have any inquiries or thoughts, we'd love to hear from you, and thanks so much for your time.
Thanks, Chris, and thanks everyone.